So there have been several studies on the genetics of prostate cancer, and it is difficult to have anything but awe for this incredible achievement. So many men involved from so many different parts of the world, so many different genes were evaluated, very sophisticated statistical methods to try and work out what might be a false signal versus a true signal. It really is one of the towering achievements of prostate cancer in the past 5 to 10 years. The problem comes trying to apply those findings clinically. Obviously, they're very interesting biologically. We could look at some of the genes that have been associated with prostate cancer and think about pathways and carcinogenesis. But how would you use them clinically? And it has been suggested in several papers that what we do is that we use these polygenic risk scores. And you can think of a polygenic risk score as just how high is your risk of having prostate cancer. A high polygenic risk score means you're very high chance of getting prostate cancer. A low risk means you're not. How would you use them clinically? And the suggestion is, well, maybe we should only screen those men at high risk. So we're going to restrict screening. If you're a low risk, you don't need to be screened at all. If you're a high risk of having prostate cancer, you should be screened. The problem with that is that every man is going to get prostate cancer if they live long enough. Prostate cancer is not the problem. It's prostate cancer morbidity and mortality, METs and death. And what we want to do in a screening program is find the cancers that are likely to lead to morbidity and mortality. The number one problem we have in PSA screening is overdiagnosis, of course, and leading to overtreatment. Now, if your endpoint is getting cancer, is diagnosis of cancer, you're not actually going to solve that problem. So that's the sort of general philosophical background to it. It seems like it shouldn't work, but you can actually do some math to find out whether it does work or not. And what we did is we created a very simple net benefit formulation. You can think of net benefit like net profit in business. So in business, your profit is your income minus your expenditure. In medicine, your net benefit is, well, what you get and what you have to pay for it. In screening, what you get is lives saved. And what you have to pay for is people that you have to diagnose and the people that you actually have to screen, right? We've got to go and run around in breast cancer giving large numbers of people mammograms and then biopsying some of them, even if it's negative, even if the biopsy turns out to be negative. That's a bad thing. That's something we're going to have to pay for, in a sense, or pay. I'll put that in quotes. And then obviously, if a woman gets diagnosis of breast cancer, that's a bad thing. That's something we're having to sort of pay for because it causes treatment and obviously huge amounts of anxiety. So in the net benefit formulation, we say, how many lives are we saving? And then we're going to take into account the number of people we have to screen and diagnose in order to save that number of lives. And what we can do is we can say, well, let's imagine that there was a marker that had certain properties. It found a certain percentage of the cancers at different thresholds of that marker. And we made an important distinction, a marker that does not distinguish between mortality and incidence. And that is the case with polygenic risk scores. This is the absolute critical fact that the hazard ratios for incident prostate cancer and fatal prostate cancer are pretty much exactly the same. So once you have prostate cancer, the PRS does not predict whether you're going to die from that prostate cancer or not. So we looked at a marker that has that type of property, or a marker that actually predicts mortality better than it predicts incidence. And of course, the very well-known marker that actually does that is PSA. PSA is much better at predicting aggressive prostate cancer than any prostate cancer. And what we could show using this very simple mathematical approach is that stratifying screening, meaning only screening a subgroup of the population at higher risk from a marker, is very unlikely to help, or will only help an extremely restricted number of scenarios unless the marker distinguishes mortality better than it distinguishes incident cancer. Now, the interesting exception was lung cancer. Lung cancer, it's like, if you can work out who's going to get lung cancer, it doesn't matter whether you think they're going to die from it or not, then you should only screen those people who are at high risk of lung cancer. And interestingly, that's the current status quo, right? Only if you've got a certain number of PAC years do we give you CT. We don't do CT lung screening for everybody in the population. That's in distinction to mammography or the pap smear or the PSA test, where the general guidelines right now are everybody at risk should either get the mammogram or pap smear or should have informed consent discussions about PSA. That's the current status quo. Risk stratifying by a marker that detects does not differentiate between incident and fatal disease is not going to improve net benefit. It'll in fact decrease net benefit. And so our advice was, first of all, we should not select men to be screened based on their level of a polygenic risk score that predicts incidence. And secondly, we think that new polygenic risk scores could be created with the endpoint of prostate cancer mortality rather than prostate cancer incidence.